Heyo, Henry here with another video. Today I wanted to look at why understanding how to search for evidence and scrutinize research methods and statistics is absolutely necessary, but not sufficient to practice medicine. I feel kind of silly that I need to even say that phrase, but critics often malign evidence-based medicine as a practice that turns an individual into a number, where the physician replaces the patient for the population and a guideline. Today I'm going to double down on the ridiculousness of repeating the obvious by discussing why evidence-based medicine is simply a tool within the larger scope of what it means to practice medicine. The majority of medical education and training is comprised of rote memorization and personal experiences. Doctors, myself included, are not great with appraising the medical literature. We haven't been adequately trained to be. And unfortunately, in order to start a conversation about benefits, harms, and preferences requires an ability to do so. Although not sufficient, the skill set is absolutely necessary. So it is disheartening to me when I read a study of 11 residency programs that found that nearly half the residents could not correctly determine specificity nor interpret the meaning of a p-value, nearly 9 out of 10 failed to correctly interpret a 95% confidence interval, less than 20% could determine the strength of evidence for risk factors, only about a third could even identify a chi-square analysis or interpret an odds ratio in a multivariate regression analysis. I point out the last two for my pediatric friends, because a study of the pediatric medical literature showed that the most commonly reported statistical tests were chi-squared and logistic regression. You would struggle with about a third of the pediatric literature if you could not identify or interpret those results. Perhaps more alarming is that the senior residents in that study of 11 residency programs were worse at interpreting medical statistics than junior residents. Apparently, medical training is serving fish without ever giving a casting lesson. Perhaps practicing doctors develop appraisal skills once outside of the grind of residency. Nope, they suck too. A study found that most primary care physicians could not distinguish between irrelevant and relevant statistics. When questioned about cancer screening, they failed to realize how lead time bias and overdiagnosis influences spurious outcomes and that the mortality rate, not the survival rate, is the useful statistic. Several other studies have demonstrated that doctors are exceedingly poor at estimating health risk for their patients. And if only 30% of doctors can correctly rank outcomes based on the strength of evidence they provide, then it is not surprising that drugs like Atenolol is still in the top 50 drugs sold despite the quality evidence published over a decade ago showing that it has no effect on mortality. So yeah, it's necessary. You cannot memorize or experience your way to better medicine. Doctors memorized Galen airs for centuries, and they really felt that they were experiencing their patients improving with bloodletting, mercury, and sulfuric acid treatments. Evidence-based medicine is a tool, necessary, but not sufficient. There are many factors that go into being able to adequately communicate the best available medicine. And I want to briefly touch on the topic here just to appease some of the critics. Many times in medicine, there are decisions that have to be made where the science is not very robust. Inevitably in these situations, some physician chimes in with the trope, "This is the art of medicine." I wonder if that's what the doctor really thinks about architects and painters when they are working. Can you take a little evidence out of there? And then you'll have it. Now you don't know what you're doing. Masterpiece. Art in a broad sense is communication, where care is directed into the medium in which the message is being delivered. It is the difference between saying, "Tuberculosis sucks, but I'm strong and I will get through it," versus Henley writing, "Beyond this place of wrath and tears looms but the horror of the shade. And yet the menace of the years finds and shall find me unafraid." Both convey the same message. The medium is the written word. One is art, one is not. There is thoughtless use of concrete, and then there are buildings by architect Tada Ando. One is art, one is not. The art of medicine is being able to communicate the best available medical evidence in a thoughtful and compassionate way that allows an individual in most, not all, circumstances to make an informed decision that aligns with his or her preferences and life circumstances. No matter how good the data, two individuals with the same options may choose differently because, well, they are different and have different preferences. This is taking into mind that we all make decisions that are not in our best interests. We eat and drink too much, exercise and sleep too little, and we all make decisions we regret. With all that said, the way the message is delivered will influence a person's decision. Two well-known examples are prospect theory and default positioning. For the first, imagine you have to choose between two treatments, A and B, for an infectious disease that will cause 100 people to die. If you choose treatment A, 30 people will live. If you choose treatment B, then there's a 30% chance that all 100 people will be saved, and a 70% chance that no one will be saved. Which one would you choose, A or B? Okay, got it? Let's do this again, but with two different treatments, C and D. If you choose C, 70 people will die. If you choose treatment D, there is a 30% chance that no one dies, and a 70% chance that everyone dies. Which one would you choose? When presented with both scenarios, you can clearly see the outcomes are the same, but people tend to choose treatment A in the first scenario, but treatment D in the second scenario. The first was framed as a gain with high probability, which promotes risk aversion in decision making, whereas the second was framed as a loss with high probability, which promotes risk-seeking decisions. Likewise, decisions can be heavily influenced by the default position in which the choice is presented. For example, in culturally similar countries, the rates of organ donation depends on whether the default is to check a box, yes, I would like to be an organ donor, versus I do not want to be an organ donor. The choice is the same, but the outcomes are not. Lastly, the form in which the information is delivered matters, whether it is written, spoken, made into visual displays, or all three can impact choice. The art of medicine is to present the information in a way that will set individuals up to make a choice most consistent with the person he or she would like to be, and will be less likely to regret their personal choice. Physicians can and should be respectful partners in the process, but through the very act of being the messenger, physicians cannot be indifferent participants in shared decision making. That is why the study of ethics, culture, and diversity are integral parts of a doctor's training. I could go on and on about how beautifully complex this deeply personal process is, but it is a little putting the cart before the horse if you cannot discriminate between differing levels of evidence and are not able to correctly interpret the data presented in studies. You cannot begin a discussion about the benefits or harms of a decision without being proficient at appraisal. I simply do not understand the criticism of evidence-based medicine. It only adds to the art of medicine. It does not subtract. As always, thanks for watching, and until next time, stay donkey.